Hello, I'm Rosalind Nieves. Welcome to Health Corner. I'm going to take you to Howard Beach to talk to Dr. Benjamin Bieber. He's a physical medicine and rehabilitation regenerative specialist who's going to provide us with the latest information on non-surgical orthopedic medicine. The key factor in regenerative medicine is that it's non-surgical. Why should you go under the knife if you don't have to? Time and time again, people are making healthier choices. Organic food, minimally invasive, or even non-surgical procedures to improve their quality of life. So stay tuned, and if we have enough time, we'll even take a look at a procedure. Let's go over to Howard Beach. What is regenerative medicine?
Thank you so much for being here, all of you. Thank you so much, because it's so important that people are aware of regenerative medicine. Not many people know about it, and it's a great non-surgical orthopedic approach that will prevent people from having surgery.
What type of cases can it help?
It can help patients with mild, moderate, and severe arthritis of a joint, such as the shoulder, the elbow, the wrist, the hand, the hip, the knee, the ankle, and the foot, anywhere from mild to severe osteoarthritis of that joint, even bone on bone.
How does it benefit the patient?
It benefits the patient because it has a very high success rate, and very important, it is a tremendously, tremendously safe procedure.
What is the downtime?
The downtime for platelet-rich plasma is they cannot be on that extremity, put weight on that extremity for 2 days. And for stem cell therapy, they can't put weight on that extremity for 3 days.
What is stem cell therapy?
You can obtain stem cell therapy from your own body. One area is the adipose tissue. The adipose tissue is the same thing as fat. And we found that fat has many, 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 many stem cells. So that's one area. Another area where we obtain stem cells is the bone marrow, and the bone marrow is inside the bone.
Do you have a case for us today?
In fact, I do. I have a patient who has a lot of medical issues. He does not want to have a knee replacement, so the alternative is I'm going to be doing a fat-derived stem cell procedure on him, which affords him an 80% success rate. And then what's important is stem cells last a year or longer. The platelet-rich plasma is more short-lived. So then in 4 to 6 weeks, we just do a booster platelet-rich plasma injection. Because the platelet-rich plasma, what it does, it helps to multiply the stem cells as well as bring the stem cells from the periphery into the area of damage. The pre-op for this procedure is the patient should not take any anti-inflammatory medication a week before, which is very important, and should not take any anti-inflammatory after, because anti-inflammatory medication is toxic to the stem cells. Also, I give patients Valium to take 1 hour, Valium 1 hour to take before, and every hour as needed. I also put the patient on prophylactic antibiotics the day before the procedure, the day of the procedure, and the day after the procedure.
The first thing we do when the patient comes in is we check their blood pressure. We make sure that they have a stable blood pressure. If it's too high, we have them take either a pill for blood pressure or have them relax. Typically they are relaxed because usually they take a Valium so that they're nice and relaxed. Then we draw 50 cc's of blood. 10 cc's of it will be anticoagulant, just prevent the blood from coagulating or clotting. And this is what we draw. So this complete tube of blood. Once it's drawn, we input it into this device. We put it into the centrifuge so that we could spin it and separate the blood and the plasma.
What's also great about the platelet-rich plasma, it helps the stem cells to multiply. Not only that, it helps the stem cells to migrate to the area of injury.
To make it pure, we spin it twice. Some doctors, and you can use it with one spin, but we want to make it as pure and concentrated as possible. So from 50 cc's, we get about 7 cc's of platelet-rich plasma, anything between 5 and 7. We get 20 cc's left of poor platelet-rich plasma, which is very good to use as well, and that is what we concentrate into this device. This device takes out the protein from the plasma, the poor plasma that we have left, which is about 20 cc's we get left. That's about this much cc's of plasma. Once we concentrate it, we're left with this much. So we can concentrate it down from 20 to 1 cc's, 2 cc's, depending on how much the doctor would like to use or how concentrated he wants it. Once this is done, we have left would be this, and this is not put into this device. This is directly taken out of this one. And this is what we get left with 5 cc's of PRP, platelet-rich plasma. So we combine these two. What the protein does, the protein is kind of like a stage for it per se. So it'll keep the plasma and the stem cells in one spot. So if we're injecting the patient in the knee, we combine it together and it keeps it in one area.
I go to the patient and we do a mini lipo aspiration or a mini liposuction. And it's amazing. It is so safe. All I really do is, first of all, I use the ultrasound machine to look at the layers, to look at the anatomy of the abdominal wall, and to see where all the fat is. Okay, can you freeze it for me, please? This is all fat right over here, and which is adipose tissue. The same thing as fat, and then you have something called Scarpi's fascia, and this is all fat over here. So this is where we're going to be obtaining the adipose tissue, the stem cells. I numb up underneath the umbilicus, also called the belly button, and we put a little needle in, a very baby one, and we numb the area up. And then after I numb the area up, just that one little hole, I take another needle and I pluck a little hole, just with a little needle. I use a cannula. It's like a very thin pencil, and I go into that same hole and I numb up the area. This, what I'm using right now, this is a cannula, and we're using 1% lidocaine. We're using a local anesthetic with some normal saline to dilute the anesthetic. We want to do that because a high concentration of anesthetic is not good for the stem cells. Okay, if anything bothers you, let me know. A little pushing now. So after that, we wait around 15-20 minutes, and when everything is numb, we go back into the same hole, and then I remove the fat cells. Fast. We prepared it well. It usually comes out a little slower in the beginning than faster, but everything is just going just perfect and quick and perfect, just perfect.
Where are you going to get the stem cells?
Well, you can get it from many different areas. You can get it from the thigh, you can get it underneath the belly button, you can get it from the buttock, but I always get it from no matter how thin they are, I get it from underneath the umbilicus, the belly button, because I use the ultrasound machine to see exactly, even no matter how little and how thin they are, I can find the fat, and I can find the area using diagnostic ultrasound, by using the ultrasound machine to find the exact layer of fat. Ever see it come out so fast?
Yeah.
Huh? Want to pull this out? Let's see, I got it. Okay. Okay, here's some more of the stem cells, fat stem cells in here. But it's in there, and we're going to separate it later on. There we go. And then after that, we put it in a special type of centrifuge, and we separate the fat cells from the stem cells. Okay, so this is it right now. Now we're going to be processing this. And this is the combination of the fat cells and the stromal vascular fraction. And we're going to take this and we're going to be putting it into the special centrifuge, spinning it around, which will separate the fat cells and will obtain the mesenchymal stem cells. and that's what we'll be using to inject into his knee.
Once it's processed, we get, depending on how much, in this case we got a lot, we got about 18 cc's of stem cells out of the fat. So that's a lot. We want at least 12. So sometimes we get more. So it really depends on how much fat we get out of the patient. But we don't need more than this. This is plenty.
Okay, Mr. Devaney, as I said before, has severe osteoarthritis of the left knee. So today we're going to be injecting with stem cells the joint, the lateral collateral ligament to give more stability to the knee, and the medial collateral ligament to give more stability to the knee. So the first thing we're going to do is inject the lateral collateral ligament. And right now we're just going to numb up the lateral collateral ligament. Okay. All right, you're going to feel a little needle now. You ready? That's it. And we're just going to numb up the area. Good, that's it. Okay. So we did that, and now we're going to perform ultrasound-guided injection of the lateral collateral ligament. Okay, another glove. Okay, so what we can do right now is we can see in this picture, we can see the lateral meniscus, and we can also see the lateral collateral ligament, which we're going to be injecting. Okay? Okay. So over here, you can see the lateral meniscus, this triangular shape is the lateral meniscus of the knee, and all this stuff right here is a lateral collateral ligament. So we're going to be injecting all along the lateral collateral ligament to make it strong so his knee isn't wobbly and his knee is nice and strong.
Again, doctor, what type of cases can it help?
It can help many. Let's start with the shoulder, and I'll work down. With the shoulder, it's indicated for mild, moderate, and severe bone-on-bone osteoarthritis of the shoulder. It's used many times. I use it many times for rotator cuff tears, a partial or a complete rotator cuff tear. And a rotator cuff tear is a tear of one or several tendons of the rotator cuff. I've also used it for when there's a tear of the glenoid labrum. And what that is, that's a cartilage, and if that's torn, it can cause instability to the shoulder. So I also use regenerative medicine for a torn glenoid labrum, which causes shoulder instability. Now, going down to the elbow we use a lot. It's a high success rate for tennis elbow. You know, if patients had steroid injections or physical therapy and it hasn't helped, most people have to go for surgery, but it works beautiful with platelet-rich plasma. And then there's something called golfer's elbow, which is the medial epicondylitis, which is in the inside of the elbow, and tennis elbow is on the outside of the elbow. And of course, it's used for mild, moderate, and severe joint arthritis of the elbow. Going down, it's also used for the wrist, any kind of arthritis for the wrist, mild, moderate, severe. It's used for severe tendon problems of the wrist. There is something called, which is a very common clinical entity, called decurvaneous tenosynovitis, which is very, very common at the wrist, and it's also used for that for that diagnosis. Going down to the hands, it's used for osteoarthritis, mild, moderate, or severe. It's also used for any kind of tendon or ligament injury, for trigger finger. And now, going down to the lower extremity, we'll start with the hip. The hip is used for mild, moderate, severe bone-on-bone osteoarthritis of the hip. It's also used for a clinical entity which has a high success rate of something called avascular necrosis of the hip. And what that means is there's diminished blood flow to the hip, and what that does is it causes dead bone.
So with this procedure, you wouldn't require a hip replacement?
There are many patients that I've treated with advanced arthritis of the hip, bone-on-bone arthritis of the hip, and they did not need a joint replacement, a hip replacement. So yes, there's a 75% success rate with stem cell therapy for severe osteoarthritis of the hip. There we go. Now we can see the needle. And we're going to bring it down a bit. And the important thing is that we see the tip. Let's do the needle enhancement, okay? It'll be better. Hold it. Okay, so you can see the tip. Let's take a look. Ooh, wow, look at that picture. So that's the picture. You see it, see it right there? So we're going to inject a little of it. You ready? It may hurt a little going in. Beautiful. And now we're going to inject. We're going to come back. There we go. And you can see it over here too. Hold it. Okay, we're going to give a little more. And we're almost finished. There we go. Look at that beautiful picture of it going in. Held it. And you can see we're going to go over a little more here. And you can see it beautiful over here. I want to get a little more in. Right there, which is perfect. If you can see the... So now you can see the needle tip going right into the lateral collateral ligament. And we're going to inject the rest of it. It may hurt a little going in. Done. The stem cells are amazing. I'm just so excited about it because stem cells are undifferentiated. They're really nothing. Well, they're really something. But what happens is, arthritis is a lack of cartilage. If it's mild arthritis, it's a small lack of cartilage. If it's severe arthritis, it's a lot of lack of cartilage. And if it's bone on bone, there's no cartilage. So what the stem cell does is it becomes cartilage. It becomes cartilage, and then in a year, if you take an X-ray, you can see that the joint space widens.
So let me backtrack. You're telling me that people had no cartilage, the stem cells actually transform into cartilage?
Yes, exactly. And it's the same thing. That's exactly correct. It's perfect. And it's the same thing with a rotator cuff tear or a big rotator cuff tear of tendons. The problem is the tendon is torn. It becomes tendon.
I have a lot of people having knee replacement and those type of procedures. Are you telling me that the stem cells can help bone-on-bone problems?
You know, that's a great question, Roz, because the greatest success rate is the knee. So if someone has bone-on-bone, severe osteoarthritis of the knee, there's an 80% success rate using a stem cell procedure. 80%. Okay, so we're going to give a little more of, what's in here is stem cells, platelet-rich plasma, calcium chloride, as well as the protein concentrate. So he's got it all. We're giving him everything. Okay, so now we're going to back it up a little. Let's see if we can get a little right over here. What is that? Here we go. Here we go. Okay, you okay?
Yeah.
We're almost finished. And here you go again. You can see it well. We're right in it, right there. And this is the last one. Done.
Again, what is the downtime?
The downtime is amazing. For mild to moderate osteoarthritis, I use platelet-rich plasma. I use it for tennis elbow and many other things. The downtime is only 2 days. 2 days. They just cannot be on that. Let's say it's the leg. They just can't put any weight on the leg, and if they have to get up, they need to use a cane to get up. So it's only 2 days. For a stem cell procedure, it's only 3 days, and then they can start walking. So there's really no downtime. If they want to go back, if they want to go back to work, which is not too physically demanding, they can go back. If it's a stem cell procedure, I like around a week. Now we're going to go to the medial collateral ligament, and that's. Hey, let's get back. That's perfect. Let's get rid of this. Okay, great. That's perfect. So let's just see what we got here. So now we're going to find it over here. Or we're going to try to find it over here. Okay, so we'll freeze it. Let's just get a better picture over here. Hold it.
You have to numb that area?
Oh yeah, definitely. We're numbing every area for you. Every area we numb first. Excellent. Good. Okay, so over here, this is right over here. This is the space with the medial meniscus is in here. This is the medial meniscus, and this is the medial collateral ligament. So we're going to be injecting all along the medial collateral ligament to enhance the stability of the knee. Okay. Okay. Have the number 2, the marker number 2. Just pressure, and just pressure. Okay. That's it. Okay. Stay just like that. A little stick now. Okay. Please put it on the needle enhancement. And you can start seeing the needle now going good. Now we're just going to make it a little deeper. You can see the needle again going in. Okay, now, and you can see it right there. Look at the tip. There's the tip of the needle. You see the tip right there?
Oh, yeah.
Okay, good. So now we're going to do a little injection. It's made her just a little bit.
Yeah, 2.
What? We have another one?
Yes, sir.
Okay. Oh, thanks for telling me. And now we're going to go. It's a long ligament. So we're going to hit different areas. You see? So look at the tip of that. You guys see it? You see the tip, guys? And so we're hitting the another part of the same ligament. Make it. Okay, so we're doing that right now. And I think we're perfect. Good, that was done. There you go. Okay. Little stick. That's it. So the key is you want to always see the tip, and let me just make sure we're okay. And this is beautiful. You can see the tip beautiful, so we're going to inject right into the ligament. Done. You all right?
So far, so good.
Good.
How long does it take for stem cells to transform to cartilage?
You know, that's another good question. I can just say that in a year, they've showed studies and they've compared. However, the most important thing to me is I don't even think about that. I think about how the patient feels, how the patient functions. Can the patient walk better? Can the patient have less pain going from the sit to the standing position? Can the patient go up and down the stairs? Can the patient function better? And that's my big concern.
Who can have this procedure?
Anybody from a child to a patient 100 years old or more can have the procedure because it is so safe. I've performed the platelet-rich plasma on a patient whose bone wasn't healing, had a fracture, and it wasn't healing fast enough. So I used platelet-rich plasma, and it healed the bone. And it healed it very quickly.
Can you donate stem cells to a relative or sibling?
No, we don't do that. We keep the stem cells, and it's for the. We use the same stem cells for the person who we're doing the procedure on.
Thank you, Dr. Bieber.
Thank you, and thank you for having me.
If you missed any part of this program, just go to www.qptv.org to view the program online. Don't forget to like us on Facebook and follow us on Twitter. I'm Rosalind Nieves, and I'll see you next time on Health Corner.